Hello, my name is Ian McCall, and this is another in the series of consultations in dermatology from the Australian Institute of Dermatology. Today we're going to look at Hailey-Hailey disease, and I've titled it The Groin That Cracks, because you know the highlight, the archetypical feature that you're going to see in this condition are these cracks or fissures in the epidermis. And you'll see them in flexures, like under the armpits, under the breasts, and in the groin, sometimes in the back of the neck as well. The other name that's sometimes given to this condition is benign chronic familial pemphigus. But you know, pemphigus is an autoimmune disease, and Hailey-Hailey isn't an autoimmune disease. In pemphigus, there are antibodies that attack the desmoglein proteins that hold the keratinocytes together in the intact epidermis. But in Hailey-Hailey disease, these desmosomes, as they're called, made up of these proteins, they're abnormal. They're genetically abnormal. So the cells have a propensity in the epidermis to split, to fall apart, and hence these splits or ragads or erosions occur in the skin. Now this is inherited as an autosomal dominant disorder. But generally, it's going to not really present until you're about 30 or 40. And that's when you get it in these flexural areas. It's particularly worse in warm weather with sweating. And also that encourages some secondary infection and friction. Activities that involve a lot of friction in the skin tend to cause this to come out. Doesn't affect the mouth as against ordinary pemphigus, which certainly does. And sometimes the fingernails, if you look at them, they may have some longitudinal white lines, which are seen in these nails, as against the red lines that you see in another condition called Dahlias disease. And there are some other diseases, excuse me, that have what's called acantholysis. That's the pathological term that's used to describe the separation of the keratinocytes. And Dahlias disease is one, and transient acantholytic dermatosis or Grover's disease is another. But it's Dahlias that can look similar to this, but we'll show you some pictures of that later. Remember, this is an autosomal dominant disorder. That means that half the kids can get it. If one parent's got it, then half the kids can get this disorder. It doesn't mean to say they will, but theoretically they can. Let's have a little look at the images here in this format. Here's a close-up. Look at these splits that are occurring here. There's some maceration of the epidermis here as well. It's white and soggy. There's some crusts there suggesting the secondary infection, and very often there's secondary both staphylococcal and candida infection when there's a flare of this condition. As I say, it's mainly the summer months that this comes up. Some people can get through the winter months quite nicely. But in the summer, with sweating, this comes up. This is just a better close-up to show you that maceration of the overlying epidermis here and the splits that are occurring deep within that epidermis. Now, if you look at this histologically, this is the process you see here. This is acantholysis. This is separation. These are the keratinocytes in the epidermis. These are the cells that form the top layer of the skin. And these are breaking apart, and you get these splits appearing within that epidermis. And this is acantholysis. And this is where the desmosomes that link these cells together are abnormal, and so the cells just separate and float apart. Splits occur, and if there's enough splitting here, you can imagine how a whole layer will come up as a blister. These blisters, though, aren't terribly intact blisters. They burst easily, and so it's mainly crusts that you'll see. Here's a typical picture in the groin. Here you can see the maceration here, and here you can see the splits. This is extending onto the surface of the scrotum. Some people, when they see it at first and it's just in the groin, think that it's some form of tinea infection. But remember, tinea will tend to give you some clearing in this area here, and will have a spreading scaly edge here. And paradoxically, tinea seldom involves the actual scrotal sac. There's another view under an armpit. again, you see those characteristic splits. I mean, there's obviously other flexural rashes that you can get that, you know, are your differential diagnoses. For instance, seborrheic dermatitis or psoriasis may occur in flexural areas as well, or simple intertrigo from sweating. But none of those will give you this. And if there was a lot of candida, you'd tend to get some little peripheral pustules. Now you've got some here, these little things here. These are called satellite lesions, and that just indicates there is a bit of secondary candida superimposed on this. And that's just because the skin barrier is broken, because it's macerated, and hence you've got the candida. Here's just an example under the breast. Again, look at the maceration, look at the splits that are occurring here. And I've commented here, these are the crusts of secondary bacterial infection, and some little satellite pustules, not terribly obvious there, but some little satellite pustules of candida, showing that secondary infection plays a part. And it certainly exacerbates the degree of splitting, the degree of maceration. And in the treatment of this condition, you've got to deal with that secondary infection. You can't really change the underlying genetic nature of this individual, but you've got to look at ways of reducing sweating, treating any secondary infection, treating any friction that's there as well. There's an example of it on the back of the neck. Now, it'd be difficult. You'd look at that and you might say, oh, it's an infected eczema. Perhaps it's some form of contact dermatitis. And it can be a tough diagnosis to make, because this can look very infective and very dermatitic. But luckily, if you do put a topical steroid on this, and if you do put a topical antibiotic cream, it'll usually help, whether you've thought it was an infected dermatitis and treated it as such, or whether you appreciate that it's Hailey Hailey with secondary infection. This is another older case of Hailey Hailey here, and in this patient, you've only got these annular, sort of slightly crusting lesions here, much less obviously than the other, and you'd be forgiven for thinking that that might be a tinea. It might be a little bit of staphylococcal impetigo in areas like this. And sometimes the condition can be misdiagnosed as such. There's the lateral view in this patient. It would be tough looking at that to make a definitive diagnosis of Hailey Hailey, especially when you're not looking in the flexural areas. There's another example. And again, not as gross, not really under the breast, a little bit, but more here on the anterior chest wall. Here you've got a lesion. There's an erosion in the surface, a bit of crusting here, bit of crusting here. Difficult diagnosis to make just from that. You'd normally look at that and say it's a little bit of impetigo with staph infection. There are other conditions that can also cause acantholysis, or have acantholysis as part of their histopathology. This is one of them. This is Dahlias disease. This was Dahlias in the groin, and you can see a very similar picture to Hailey Hailey. Some maceration here, a lot more papules actually in Dahlias. But again, look at those splits. So that's one of your main differentials to keep in consideration. If you think someone might have Dahlias, go have a look up behind the ear especially, and you'll see a lot more papules often. This one's showing more erosions and a bit of crusting. So I think you can appreciate the differences. Look at the nails though. In Dahlias, you'll get red lines like this, whereas in Hailey Hailey, they tend to be white lines, horizontal lines that you're going to get, whereas they're red in Dahlias disease. So let's have a look at some clinical examples here and see. But actually, before we go into the treatment, let's just look at this last slide. How are you going to deal, what is the treatment of this condition? Okay, we said you can't change the patient's genetic defects. You can get them to avoid sweating as much as possible. Give up gym work if that's going to have you sweating excessively with friction and is going to cause these to come up. Try and lose weight. It's obviously worse, this condition, if you've got occluded surfaces, and again the sweat's accumulating there. You get a bit of secondary infection in there, and that seems to in itself precipitate the full-blown lesions of Hailey Hailey. Antibiotics, both orally and or topically, and antifungals topically. Do a swab first though, and just see what's growing there. Topical steroids. Needs fairly strong topical steroids. Things like half-strength or full-strength betamethasone, you know, Elufrat, Novasone, half-strength betnavate, that type of, or Elicon, that type of strength of topical steroid. Hydrocortisone won't really do much at all. There are a few other things that have been shown to be of some benefit in Hailey Hailey disease. Topical calcipotriol cream is one of them. You know, this is, in Australia, it's called Divanex, and it's used in psoriasis. It has a curious effect on changing calcium levels in the skin. And in Hailey Hailey disease, and in Dahlias for that matter, there's a problem with a calcium pump in Golgi apparatus. And in some way, you know, calcium here must have some beneficial effect. It can irritate this, though, in those flexures, so that's the only thing you've got to watch. Tacrolimus is an immunosuppressant drug, and you'd be thinking to yourself, why is that of any benefit in a drug that, in a condition that isn't in fact an autoimmune disease? But it's like many things. I think part of the inflammation in Hailey Hailey is mediated by lymphocytes, and topical tacrolimus seems to reduce those and reduce some of the inflammation. Again, this stuff can sting a bit. It's 0.1% ointment. So it can be used, and it should be something to consider. Botulinum toxin's used because that reduces sweating. So in the axillae, if you're tending to get your Hailey Hailey there, if you're using botulinum injections in that area to reduce sweating, that can be beneficial. Rarely in severe cases, you may use oral steroids. Again, they're just markedly anti-inflammatory. A drug called Dapsone can be used. And occasionally acitretin, though I haven't had any great success using that myself. I usually don't need to anyway. That's a retinoid, usually again used in psoriasis. And lastly, ablative laser therapy. It's a curious phenomenon that if you use a CO2 laser, an erbium laser, and ablate the epidermis in the axillae or in the groin, but still leave a bit of the follicular epithelium there, lining there in the base, that when you get regeneration from that follicular epithelium, it doesn't seem to have the same genetic defect that the overlying epithelium had, and they can get a normal layer of skin forming. Now, unfortunately, it's a fairly messy process when you have ablative laser therapy, and in those areas can take a while to heal. And you've got to watch you don't scar them, but that therapy can be used for difficult areas that if you're tending to get a flare just in one area, then this can be a useful therapy to consider. Let's have a look at some of these cases. Here was an elderly lady with erosions and crusts in her forearm, so she's presenting like this. The weakened epidermis, some erosions, bit of secondary infection and crusting, and then in the folds of her abdomen, she's got this lesion here, and if you were to enlarge this view, you'd see the characteristic little splits in the epidermis here that are a feature. So here, swab it, treat it with some Bactroban cream, which will deal with both staphylococci and with Candida, and treat it also with a topical steroid like Elufrat or Elicon. And even though that's an included surface, you won't need to use it, these strong ones, for too long, and it should knock that back quite quickly. If there was very extensive erosions, you might use some oral antibiotics. In the next one, similar example here, but you can see there's a lot more in the way of secondary infection. This is a case from the virtual clinical meeting. She's had Hailey Hailey for 13 years, father and grandfather as well, none in a brother or sister. Well, it's an autosomal dominant, they might have been lucky. Flared when living in Queensland, cooler climates it was better. Also occurred around the umbilicus, but mainly again this inframammary area with sweating and perhaps some friction. And then there's a fair bit of secondary infection here that is likely to be staphylococci, and antibiotics are needed with the steroid cream to get this to settle, and it usually settles with that combination. And lastly, here's another case from our Atlas, Global Skin Atlas. And this is a much more proliferative type. Look at the degree of thickening and maceration, some crusting here of the skin in the lungs. This is a chronic relapsing rash. And this is what's happened. He's had this for more than 10 years, really, and perhaps not had definitive treatment in that time. So it's been described here by Dr. Al-Sidani as hyperpigmented, vegetative, and crusted patches with an advancing peripheral border here. And the biopsy was consistent with Hailey Hailey disease. So this can occur, as I say, in the groin, and this is in the axillae, and this is the chronic relapsing type with hyperproliferation, maceration in one that hasn't been treated. Again, this would need, you try initially your strong topical steroids and your Bactroban cream. You'd have done your swab, but may need some oral antibiotics. You may need some salicylic acid cream to get rid of some of these crusts and the like as well, for the creams to penetrate and become effective. So, Hailey Hailey disease. It was named after two brothers who named it, I think, in 1939. So it's been around for a long time. We have a better understanding of the gene and the gene defect. We don't have any way of reversing this or treating it with gene therapy at this stage, but that may well become available in the future. Pemphigus vulgaris, pemphigus erythematosus, that will give crusting as well. It's probably that's the immunological disorder that you would have to rule out, but generally with the family history, the distribution, the nature of those splits, it's a diagnosis that can be made clinically. So, Hailey Hailey disease, the groin that cracks. Thank you very much.